Hello everybody. Just some housekeeping first of all, just to check that everybody can see me and just to check that everybody can hear me okay as well. So just let us know if there's any problems with that. And this is also being recorded, so what we'll do is send this to you in the next few days as well. So just thanks for coming along everybody. What I'll do is I've been sent a few questions that I've been asked before the webinar, so I'll go through those questions first of all because that may answer any of the questions that you've got. If you want to ask me any other questions, feel free to put those in the question box. So as I'm going through, if you think of any questions, just put them in the question box, that's fine. And then I can go through those for you. Okay, let's get started because we've got some questions from Martin first of all. And Martin's just asking, could you please give me any recommendation on where to buy the BioClear Matrix kit from, including the blaster, heater, composites, etc. And any suggestions on how to make such a kit or set it up using different dealers? Tricky with the BioClear system because the actual matrices in particular, you'll really in the UK only be able to get those through Optident. So the matrices, you'll only be able to get those through Optident. The blaster essentially again comes through Optident. However, with the blaster, it's basically particle abrasion. So with the BioClear blaster, that's essentially an aluminium trioxide particle. There's other systems that use, very similar oxide particles, and there's things like Cojet, but they're all very, very similar. They're all relatively fine particles and, more importantly, low pressure. So certainly Prestige Dental make a blaster. The Cojet is fine. Do be careful, some people try and use things like PerioFlow, but the PerioFlow is often too high pressure. Now the heater, again, generally that will come through Optident because it's the BioClear heater. Be careful with the heaters because the heating is such an important part of the process that you really want it to be getting up to a pretty high temperature. The new heater from Optident, off the top of my head, will get up to about 79 degrees. Don't forget, as soon as that comes out of the heater and it gets to the tooth and it's going on the tooth, it's cooled rapidly. So don't worry about kind of problems of the pulp or damage to the pulp, but if you're going to get a different heating system, I know people have done this and they've had problems basically getting it up to the right temperature so it flows really well. Then in terms of composites, that actually in a lot of respects you would have been basically taught kind of the Venus composite, which is a Heraeus Kulzer product. We like that because of the optical properties and it works very well with the BioClear. However, any composite is reasonable with BioClear. To get the composite into the ampules, they have to heat it up. So basically any composite on the market will work with the BioClear method. So the composite is less important than the actual technique itself. Now I do know that BioClear are looking at introducing their own composite, but I've tried it with several different composites and they're all fine. So essentially, yeah, it really needs to come through Optident within the UK. If you're from outside the UK, if you're having real problems getting bits and bobs, it's probably best to either email Claire directly, email me, or if you actually email David Clarke in America, he'll pass that on and he'll be able to sort out where you can get things from. Then the next question is, could you provide a copy or link to your green amber assessment form for the whole mouth as presented in the course? Now, those of you, because I think all of you are coming in for the hands-on session, we'll certainly be giving those forms out during the hands-on session. As far as I'm aware, those forms are now available to you within the complex module, but certainly those of you who come in for the course will give you those forms out. While you're on the course, I can also get Emma to email them to you, because what we're more than happy about is for you to take these forms away and change them. The forms that I use are my own ideas, and certainly a lot of it is things that I've borrowed from 5 or 6 different courses over the year. Some of them are from the American Academy of Perio, etc. So these forms are to use as you please, so we'll happily give those out when you come in on that day. And do you have any advice, recommendations on how to set and calculate fees for large, complex tooth surface loss cases? Again, we'll go through that on the hands-on when you come in, but essentially look at what you're doing. Is it going to be crowns or is it going to be composite? And if it's going to be something like that, look at what you would be charging per individual tooth and then multiply it by the number of teeth that you're going to be doing. I would advise that you be careful with discounting, because the thing you'll think is, oh, it's multiple units, I'm going to be doing more of them. However, these are often bigger, more complex cases. So what you need to do is factor that in, and it will take a little bit more time. Also factor in with large tooth surface loss or complex cases. You'll have done your risk assessment. There's often reds, maybe they're a parafunction or something. So with bigger failing dentitions, you can often expect more failure of your restorations. Not dramatic, but factor into the cost that if you're doing more repairs, etc., I would advise guaranteeing everything for perhaps a year or so. And then after that, you may need to charge for the maintenance. However, in the early stages, expect a little bit more failure because these are compromised cases. So if it's a large case, if it's crowns or composite, simply multiply this by the number of units. If it's a complex case, factor in if it's laboratory provisionals. Now, if it's laboratory provisionals you're using, check with the lab how much they're going to charge you. They could be 30, 40, 50, or even more expensive than that, so factor that in. Apart from laboratory provisionals, if you're doing your own provisionals, but you're going to have to do a second stage impression, i.e. fit provisionals, take them off and do a second stage impression, factor in the costs for that. The other way to factor costs, again, is looking if you work on an hourly rate, that if you work for perhaps, say, a corporate of some type, as a private associate, they'll be expecting you to earn maybe about £200 an hour or more. So factor in, if you think this work is going to take you 2 or 4 hours, factor in that cost as well. So say you're going to be taking off some provisionals, you're going to basically impression it, but you've already got your crown charge something like £400 if it's going to take you 2 hours. So we will talk about that more, but that's a good place to start in terms of costs. Obviously for things like full dentures and for things such as cobalt chromes, you'll have your standard charges, which is fine to use. So just be careful not to undercharge. Certainly, you know, early on in my career, when you want to do more interesting and challenging cases, it's okay to perhaps charge less then, just to get the experience as you go forwards. So that's how I would look at setting and calculating the fees. Now, we have some questions from Nicola, who at the time when she submitted the questions was up to about module 4, and which is a good question. This she asks, you know, if you're looking at improving the smile to build out the buccal corridors posteriorly, what can you do if the patient has unrestored teeth? Which is a really good question. So the best place to start really with buccal corridors, if you want them to make them look broader, first of all is whiten them. So if you do whitening with one of the whitening protocols, this will make them higher value and it will give the illusion of making the buccal corridors look wider. The second choice, which is the kind of the best non-restorative approach, is orthodontics. So during the course, and certainly during the level 2 course, we look at cases where we've done orthodontics, and the orthodontics has managed to expand out the buccal corridors. The final way, and we'll be doing all the veneer preps on the hands-on course, is essentially with posterior veneers if the teeth are unrestored, or if they're heavily restored or root filled with crowns. But bear in mind we're now getting into the realms of more aggressive and invasive dentistry. And also if we're going to be doing posterior veneers, there's a lot of occlusal criteria to look at. You would not want to be doing posterior veneers on buccal corridors if there's parafunction or if the patient doesn't have protective canine guidance. The other way potentially to build out the buccal corridors posteriorly again is if you don't want to go to formal veneers, you could do BioClear composites. But whichever technique you go for, make sure that you are making sure that these veneers, when the patient goes from side to side in lateral excursion, are out of the occlusion. And also accept with posterior veneers that there's no studies on them. All veneer studies are done on anterior veneers, and success rates are 90% at 10 years, 75% at 15 years. But these patients have good occlusions, so no parafunction and protected occlusions. My failure rate with posterior veneers is higher than my anterior veneers. My anterior veneer failure rate is virtually 0 because I'm very selective. And I know some of the questions later will come back to veneers, but do expect when you're getting informed consent, let your patient know that failure rate with posterior veneers likely to be more like 10%. It's likely to be higher because the occlusal forces, you're right under the masseter muscles here, the occlusal forces are much stronger. So yes, the next question for Nicola is what material is best for veneers if unrestored or restored? So I think we've covered that. You can do BioClear composite if they're unrestored. You can do formal veneers if they're unrestored. Then if they're restored, you're really looking at full coverage crowns. And generally for posterior teeth, the material you'll often be using will be one of the minimal prep materials. So on the hands-on, we'll be prepping Emax preps and we'll be prepping zirconia preps. Realistically, you could be using zirconia, but press-only zirconia, so there's no risk of chipping. And that essentially will have a prep virtually the same as a full veneer gold crown. If you're replacing older crowns, then you could do this with either metal ceramic, Emax or zirconia. But do bear in mind at the back of the mouth, if you're going to be going for Emax, you're going to want 1.5 to 2 mils of occlusal reduction. Next question from Nicola is if a patient comes in with crowns and veneers with subgingival margins and there's inflammation and you plan to redo the crowns, how would you undertake the crown lengthening first so the margins become supragingival? Let me not go too much into the crown lengthening because it's difficult to just describe it without the pictures or the slides. What we're going to do on the hands-on course is we're going to actually do some surgical crown lengthening on pig's jaws. So what we're going to do during the hands-on bit is when we do preps or we do crown lengthening, we'll do a very quick brief resume first of all. But essentially what you would do is you would do your crown lengthening first. So if you're replacing the restorations, then essentially you'll probably have a wax up. Or if you're not changing very much about them, you'll have a study model. You can get your stent made from the study model, and your stent will be made to where your restoration margins are going to be. You'll then do your flap elevation back, and from wherever the stent is, you'll then place your bone 3 mils away from that. So that's what you'd need to do. Now, if your margins are subgingival and you don't have a stent, you would measure with a perio probe 3 mils away and reduce the bone back by 3 mils all the way around on the buccal, just going into the interproximal, but taking care not to take the height down of the papilla too much. Then you would leave that for probably at least 2 or 3 weeks before you would prep the teeth for the provisionals. You can do it on the same visit, but it's hard work. You've got to take the flap back, do your crown lengthening, suture it, then take your existing restorations off, then make provisionals, and your stitches get caught up in the bisacryl, etc. So leave it at least a week or 2. So if they're very fussy aesthetically, leave it a week or 2. And you can have a problem because particularly if they're non-vital or dark teeth, you have your veneer or your crown, then you have a dark tooth and the patients don't like it. How long would you ideally wait? Possibly 3 months or so, 4 months. But if the patient's fussy, you can go ahead to the provisionals within a couple of weeks and then leave those for about 3 months. That's fine. That's no problem. Next question was from Nicola. If the patient has a discolored central incisor, which is non-vital and wants to improve the appearance, and a veneer is appropriate, and the other teeth are unrestored, is a single veneer always best, or would you place veneers on the other incisors to match it? Really, Nicola, this is probably the most difficult aesthetic thing you'll face. The single anterior crown or veneer is really difficult to match. So first of all, get that across to the patient that the most difficult thing in dentistry is try and match porcelain to enamel and dentine. So always say to the patient, you will never get perfection with this because you've got a dark tooth first of all, and you're putting porcelain on it and you're trying to match it to normal teeth. It's not going to be perfect. So get that across first of all. So where can we start? The best place to start would be, if it's a discolored non-vital central, is internal bleaching. So do in-out bleaching, open the back of the tooth up, place something like a resin-modified glass ionomer over the root filling. So drill out the gutta perca to below just gum level, put in something like resin-modified glass ionomer, then bleach on the outside and the inside of the tray, and they put that in and they can change that a couple of times a day for 4 or 5 days. Maybe get them to basically do that maybe from Monday to Friday until the colour comes up. And then if that gives you an improvement of 60–70%, I advise most patients to settle for that. Problems, you may not get 60 or 70%. Fortunately, at the moment, I've been quite lucky. The last 3 or 4 I've done have been fantastic with a really good result. Sometimes they darken back down. Sometimes, admittedly, the results are disappointing. The results are often not perfect because what you're trying to bleach is basically the bruise within the tooth. It's not like normal bleaching. And the bruise basically has a lot of hemoglobin in it, which is iron-based. And these metal ions don't bleach well out of the tooth, so it can be disappointing. Then if you're going to veneer it, it's troublesome because the core is so dark. What you may often have to do is actually physically crown it and use something like Emax, but with one of the blocking cores. And when you do your prep, send a photo to the lab of the dark core underneath with something next to it, a shade A4 or something, so that basically the lab know what the shade is and they can try and match it. But be very almost pessimistic with the patient that you're not going to get perfection. Then if you're finding that it's really a struggle when you try it in, yes, really the next thing to do would be to veneer the tooth next to it. So if it's a single central, veneer the one next to it. But you would need to use a blocking core on the veneer, the same as the crown, so that it all matches in better. And the final question from Nicola was when removing composites for veneers, what should you do? Basically, should you remove the composite and bond to it? Definitely not. Take the composite out and bond directly to the tooth. There's a number of studies going back from very early studies by Dunfart and Schaefer, all the way through to more recent reviews by people like Trevor Burke and Laconi, and composites are a risk factor. If you find there's lots of composites, then it's basically going to be a crown. If you find there's a deep undercut, now be careful with this, you can actually ask the lab to block the undercut, but you don't want a thick cement loop because that's a risk factor for failure as well. So if you're finding a lot of composite there, you may be better off doing more of a shell crown. You may be better off with that. The next questions come from Jose or Jose, and we've covered this a little bit, but 10% of teeth become non-vital when prepared for full coverage crowns. Is this immediate or after X number of years? Which is a really good question. Both, basically. I do thousands of preps, and I've had teeth become non-vital literally the next day. Don't panic, it doesn't happen very often, but I have prep teeth on one day, they're non-vital the next, and I've been doing very minimal preps on them or something like that. So it can be the next day. Then it's variable. It can be 2 or 3 weeks later, 3 months later, can be a number of years later, maybe 3 or 4 years, but it will generally happen early on, and then there's a big lag phase. Now, obviously, with your consent, consent people that 10% is your kind of average. If it's a very sound tooth, you would expect more problems. But I've had teeth where I've just taken a crown off, literally taken the cement off and fitted temporary, and that's gone non-vital. When you look at the studies, it's very variable because they look at they're looking at teeth basically up to 10-15 years. So I don't find there's a big cluster of initial devitalization, and some of them lose vitality with no pain at all. So it can be immediate, but the other thing that you'll find is apart from it being immediate, it can also be more long-term as well. It's not a common problem that I'm finding. Some studies you'll see are up to about 23%, but hopefully, and you'll get to do this on the hands-on, we'll use prep through guides, we'll use indices, so you keep the preps minimal, and don't forget things like the Pashley technique, where you etch the tooth straight after prepping it. And then what you do is you put your bond straight on to seal the dental tubules. So that is a good option as well, but it can happen over a period of time. Okay. Oh, the flexible clearance guide, again, we'll have those out on the course. So who manufactures that? We get them through Prestige Dental. Now, with the hands-on course, I can't off the top of my head remember which day it is, but essentially Prestige Dental come in because they provide us with all the articulators, and they'll show you the flexible clearance guides. Also, when you're in for the course, you'll have a day and a half with Claire doing BioClear, and obviously that will be mainly hands-on. And Octodent are in on those days as well, so you'll get a chance to look at all these materials and purchase those when you've had a chance to use them. We've just had a question come in about more details on restricted envelope. Now, I'll go through that briefly, but before you come in for the hands-on, it would be worth, after this session, anything you're still not sure about, and that restricted envelope might be one of them, what I'll ask you to do is give me those questions on day one of the course, and then what we can do throughout the course when we're having a break or even on the last day at the end of it is go through any things that you're still not sure about. Now, restricted envelope, we essentially, it's not something that's written up much about in the UK. Really, the first description of it is kind of Pete Dawson back in the 1980s, and it's become very widely accepted in America. And what it is that people, when they chew, at the end of the chewing cycle, the mandible comes forwards and up a bit, like so. So the mandible becomes basically comes forwards and up in this motion. So it's not often described in the UK, and I think that's because we often look at very static occlusions in the UK. But just imagine the patient chews like that. So you can see here, if we increase the overjet, there's more of an envelope. If we restrict it, you can see the teeth hit here. Also, if there's more of an overbite, potentially there is more restriction here. And so the patient doesn't have enough room to chew, so they hit like that, and they can get wear on the incisal edges. They then skid up and get palatal wear to the intercuspal position. And then on the lowers here, they get buccal wear. So the wear pattern is enough to diagnose it. Now, how much envelope people need, we honestly don't know. It's very underreported. If you look at the very limited work there is on it by people like Lundeen and Gibbs, it's about 0.37 of a mil. So it's not much. The trouble is, you think, oh, the teeth will wear and there'll be a gap, but they don't. They over-erupt. And so the restriction just continues as the teeth wear. Basically, what I would say is these patients need orthodontics. And if people remind me about restricted envelope on the course, I'll show you some slides of it again, and it's classic. But remind me on the course and I'll show you some slides of it, because it's easier when you see the actual pictures of it and what it looks like. The danger is you crown the teeth or veneer them, they're in a restriction and they just go break, 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 or wear, wear, wear. So it's really important that you spot it. What's the incidence? Not high, maybe 10% of patients, maybe about 10%. But where it goes wrong is when people start veneering or restoring them. Don't forget you can create it yourself if you place quite buccal, if you create quite bulky crowns on, say, upper centrals. Okay. Another question that's just come through. When will you place the retraction cord for crown prep? Before prep is the first question. No, prep first. So my advice would be to prep first, then put the cord in. The danger is when you put the cord in first, you locate the gum more apically, and then your tendency is to deepen your margin, so it's more subgingival. The danger then is that you violate the biologic width. Do you need to remove it before the impressions? No. On the course, what I'll show you is the ultradent cord. That is very soft. It's a kind of knitted cord, very soft, very gentle. You can push that in, and then basically that will just push the gum out of the way far enough for your impression. And the impression material that I'll often be advising people use is the Heraeus-Kulzer product, which is Flexitime, and you'll find the wash will get right down onto those margins. So most of the time I use the ultradent cord. It's a very soft cord. I use the purple, which is the medium. Pack it in, and basically then, once you've packed it in, get your impression done as quickly as possible. If you use the very runny washes that I use with the Heraeus-Kulzer Flexitime, the cord will actually come out in the impression. The material flows so well it pulls the cord out of the impression, and it works really well. So that would be what I would advise. And if again people remind me, I'll show you that cord on the course, and we can have a really good look at that. But essentially that would be fine. So where were we up to with the questions? We were really down to, with regard to removing composites, would this apply to different classes of restorations? Definitely. If you're going to do a veneer, get all the composite out, and if you find that by the time you've got all the composite out, it's looking more like a crown preparation because there's so many undercuts, go for a crown. The next thing was, when fitting a veneer, would you recommend light curing the bond prior to placing the cement and the veneer? Generally, yeah, accepted procedure would to be basically light cure the bond first. Essentially, would it be the end of the world if you didn't? No, it wouldn't. But effectively, you're going to get the bond over the whole thing, and then set the bond, and then put on your cement after that. The danger potentially is if you don't do that, you don't get an even spread of the bond. However, the other way would probably work as well. Don't forget our veneers really are enamel restorations. So because they're enamel restorations, it's not as, the bond is not as technique sensitive. We're not bonding to dentine that's moist and got collagen fibrils. We're basically bonding to hydroxyapatite. So it's a much simpler bonding procedure. Basically etch, wash, dry thoroughly, and then apply your bond. Okay, so hopefully that makes more sense to you. Okay, and we just had another question come through. What are your feelings on short-term ortho in terms of moving to canines that have migrated into the two spaces? Should I be referring to an orthodontist, or would there be any short-term system? Realistically, that would be more in the realms of long-term ortho. Short-term ortho gets a bit confusing. We use a lot of 6-month smiles here. It's not got a lot of, the short-term ortho doesn't have a lot of root torque to it. It's basically often looking more at essentially tilting and twisting teeth. But if you're going to bodily move teeth quite long distances, that would be best done by a specialist orthodontist. Doesn't mean you can't use things like clear aligners as part of that treatment, but for movements like that, I think you're really looking at more comprehensive orthodontics. Again, we talk a little bit about short-term ortho in the lectures, but if anybody wants to discuss that a little bit more when you're in, that's absolutely fine. We can go through that. So where are we? I'm considering bridging the two spaces. Watch the space. Can we go back just to there, isn't it? Can you just click on that for me? So let's just check short-term ortho. So we're moving two canines that have migrated into the two spaces. Now, if you've got, there we are. So we've got basically two canines that are in the two spaces. Now, bear in mind, this is tricky. If you've got canines in the two spaces, essentially the best thing to do is move the canines back into the canine spaces and leave the lateral incisor gaps. Now, you can disguise the canines as laterals, but it's difficult. They're darker, they're bulky, they're the wrong shape. My experience with them is they don't look wonderful. We had one of the MSc students present one 2 days ago and they looked okay. But yes, you could do, if the occlusion's favourable, and the orthodontist should be able to do this for you, resin bridge work. And you could do your resin bridge work if it's laterals, probably from the centrals cantilevering back, or from the canines cantilevering forwards. Now, if you've got orthodontics first, the orthodontist can actually create some space and almost a slight anterior open bite for you. So bridging would be absolutely fine, but perhaps go for resin bridges first of all. If you're going to go for more conventional bridges, obviously that's much more destructive. Preference would be potentially to go for implants in the lateral incisor site. But that would depend on the age of the patient, because with dental implants, if it's a younger patient, you'd really want to wait till their early 20s so that you're pretty much assured that all the craniofacial growth is completed. Okay, so we've got crown lengthening, gingivectomy and bone removal, recall, use aluminium crowns as temporaries on premolars. Not sure I fully understand the question there. If you just want to resubmit it with a little bit more detail, I'll have a little look at that. And when you choose the dial concept, so we're looking at the dial concept, when you choose to do dial composites to build up anterior teeth and wait for the posterior overruption versus crown lengthening and then restoring with veneers or crowns. So that's a good question. Now, the two patterns of tooth surface loss we see is anterior localized, which would be your typical kind of bulimic acid regurgitation. That's what the dial appliance is mainly concerned with, that the back teeth are sound. The back teeth are pretty good. The wear is very much a bit like a restricted envelope. It's on the incisal edges of the lowers, but predominantly it's on the uppers, on the palatal, and sometimes then incisal. And you would put the composite dial on the palatal. That would then basically separate the back teeth. They over-erupt, and then you can do your crowns on the front teeth. So that would be the classic time that you use the dial approach. Then crown lengthening. Now don't forget, we may also need to do crown lengthening as well. The two reasons you'd be looking at crown lengthening in those cases would probably be more severe wear. So you physically don't have much crown to put a crown onto. So if you've got less than about 4 millimeters of crown height, you may crown lengthen them then. The second thing would be aesthetics. Because what you tend to find is that if you look at my smile now, if these started to wear, they would often start to drop down as the alveolar bone drops them down. So what you can find is that your smile, the teeth are worn, but the incisal edges are roughly in the right position. And when they smile, the smile can get a little bit gummy. So if you crown lengthen them, it gives you your clinical crown height and it gets rid of that gumminess there. However, the dial appliance will create space for your restorations, which just by crown lengthening you won't get the space. So the dial will give you the space that you need. Okay. And just another one coming through. What's my opinion regarding resin bridge work using zirconia frameworks, considering that it's almost impossible to etch and bond? My opinion is basically try not to do it. Okay. I'm not sure if you get that case. I think we present the case just very briefly in the certificate course. There is a case that I think I present to you as an example. The beauty of the zirconia is it's highly aesthetic. So you get a tooth-coloured wing. The wing won't break, but it doesn't etch well, it doesn't silinate well, it doesn't bond well. So basically the lab put a layer of feldspathic slurry on, and then you etch and bond that on. There's no data on it, so there's no success rates, no data. So it's a technique you're doing purely for aesthetics. Now the case I show you in the course, the reason we did it then was twofold. The patient had had a lot of orthodontics done. They'd had a crown done, they'd had an implant done, and they'd literally run out of money. So we did the resin bridge work then. Also, her teeth were really thin, really thin. And the obvious advantage with the zirconia is aesthetically it's wonderful. So basically check here behind the teeth with a metal probe to see if any of the metal is going to come through, and get informed consent for using the metal. So if you get informed consent for using the metal, that's fine. But the zirconia, I would not routinely recommend it, but it's there if the patient's aesthetically demanding it. But warn them that the success rates, we just don't know. We honestly just don't know. Now, somebody just put a question. I've learned that the new 3M bond will allow us to do this. Off the top of my head, I'd have to be careful. There's so many new products coming out that essentially, I don't know. If you bring the details in on the course, I can have a look. But generally, what I would suggest is most of these new bonds that are bonding to zirconia, they are a little bit like Panavia, they have phosphate groups in. And certainly there are some of these bonding systems for zirconia, and what they have is phosphate groups in them. Now, there is some data on, there is a Heraeus-Colza bond for zirconia that I'm aware of and I've used. However, the evidence shows that the increase in bond strength by using these zirconia bonds, which often have phosphate groups in, is modest. So it would be fine to use it, but don't expect it to be wonderful. The bond strengths are modestly better. They're not fantastic. The next question is, would you advise to refer a patient to do crown lengthening after the practical session, or could you undertake it yourselves? We'll know after the practical session. We generally find after the practical session that people fall into three groups. There's those people who think, yeah, I'm going to go away and do it. There's those patients who think I'm going to refer it and I'm going to go and watch it, and when I refer it, and then they'll feel confident to do it. And there's certainly always a third of dentists who would basically never feel confident doing it. However, if you're going to refer it, you need to know the process of the stent, etc., because it's going to be you who's going to do the final restorations. So certainly we find people fall into three groups with that. Don't forget, as a general practitioner, your indemnity covers you for crown lengthening as long as you feel confident to do it. And choose your cases carefully. Certainly don't do your first crown lengthening case on a kind of supermodel with a high smile line. Do it on an older patient with tooth wear with a lower smile line or at the back of the mouth, and then just learn the process as you go along. So that's what I tend to find with crown lengthening. So next question would be, what would be a reasonable recall for crown lengthening for premolars or molars when you're removing bone and performing the gingivectomy? The studies tend to show that after about 12 to 12 weeks, 16 weeks, the gum line is stable. So essentially, wait 12 to 16 weeks, be more careful in the aesthetic zone with high smile lines and thin gingival biotypes. But you know, I have gone on and done the final procedure sometimes after 8 weeks or so, but just check that first of all. Safest thing, wait about 4 months. So next question would be, when doing a hemisection, how long do you have to wait to prep the tooth and fit the crown after extracting the fragment? Can it be done at the same appointment? Yes, it can, but what I would generally do is prep the tooth and fit a temporary restoration. And I would, because there's medico-legal implications here. It's a little bit like if you extract a tooth and fit a temporary bridge, you're advised to wait 3 to 4 months, generally 4 months. So I had this the other week, not so long ago. There was a bridge on a 5 replacing a 6 to a 7, and the distal root actually fractured on the 7. So I took the distal root out, and then I fitted a temporary bridge, but mainly for medico-legal reasons. I left it for basically 4 months before we did the final bridge. So it's more of a medico-legal reason. If you've actually just taken it out and fitted the crown, that's fine. There's probably very little that will go wrong. So I am not able to attend the practical hands-on sessions. Are you planning a new session next spring? Essentially, you'll need to email into Alan to check that. As far as I'm aware, I haven't got my diary with me, but I think we had set potentially dates for that in the spring. And will I get any CPD for the online part? Definitely yes. As you go through and you do the MCQs, that very much like if you were doing something in, say, the British Dental Journal and you've read the article, definitely you'll get your CPD for that part of the course. Okay. Now, another question, would it be okay to use the high speed with no air, just water spray, instead of the classic motor for oral surgery? Now, I'm presuming that's going on to crown lengthening. Yes, that would be fine. Essentially, with surgical crown lengthening, there's a distinction from removing roots. Now, when you're removing roots, essentially what you want to do is stay away from the high speed with the air on and the water, because basically, yeah, you're working down at the root tip close to the sinuses and things. With surgical crown lengthening, I've done that with high speeds, with the air and the water on, and I've done it with speed increasing, because you're really only removing the very kind of top 2 or 3 mils of the bone here. So it's fine to use it with the air and the water on. Works very well with both on because it sprays away the debris very quickly. So basically it keeps the area nice and clean. So let's just see if we've got any more questions. Oh, just asking about, oh yeah, just looking at the date. At the moment we have another hands-on session scheduled for the 6th to the 10th of February. So you may want to put that in your diary. And we've just had somebody come in who's missed the start of the webinar. Do you plan to play the recording again? Definitely yes.
We'll send an email.
We'll send you an email letting you know when. So don't worry if you've missed the start. But yes, you will get that sent out to you. So another question for the David Clarke BioClear system. If you're using this on anterior teeth, can you still add translucency and colouring to the teeth using the matrix system, or is it a block only shade that's using? Very good question, Matt. Now, basically, no, you can't. is the answer. The BioClear method really is looking at it's giving a monoblock of composite, so that's very strong, bonds really well, and is very stain resistant. So when we do the practical part, I'll be around, but it's mainly Claire who will do that with you, who did the lectures. With the BioClear, we're often looking at extending it over the whole tooth to get an infinity line, so the margin tucks down. Now, we can go through this with you on the practical part as well. If you're doing quite small composites and there's a lot of translucency, etc., in the tooth, you may have to go back to your more traditional layering technique. Do I do that? Yes, but quite infrequently. But certainly this year there's been a couple of instances where really it's going to be more applicable to actually layering and putting translucency in. And certainly with the venous composite, I find that with the venous composite you get very, very nice result with that. And we can show you this when you come in. With the venous composite, there is actually a translucent shade as well that you can use. So yeah, generally the David Clarke system we use virtually exclusively, but there is always going to be the odd instance when you do a layering technique. Will we get the pack with the consent templates? Yes, certainly. I thought this had been sent out to you. But what we can do again is, if you're finding you haven't got that when you come in for the practical, ask me at the start, and what we can do is get those copied for you, and we can also get them on a pen drive as well. So when we come in for the practical, what I'll do is I'll make sure that we get at the start of the course, I'll get Emma, who's the course coordinator, to give you some hard copies, but she can also put them on a pen drive for you as well. So that shouldn't be a problem. When would you use the David Clarke system over gingival veneers to hide black triangles? That's a really good question, because you're really looking at either a fixed option or a removable option. Now, certainly with the David Clarke system, say it's just 1 or 2 teeth, that's generally when you would definitely use it. So say there's just 1 or 2 little black triangles or 1 or 2 big black triangles, go for the David Clarke system. Now, the gingival veneers become more relevant when you've got a whole line of black triangles, because then the gingival veneer will click in between the teeth and will provide you with a very nice result. The other thing to look at is the aesthetics, because the worse the recession and the black triangle, the more that you fill them, you're going to end up with very square teeth. So it's not a disadvantage of the BioClear method, but it is just a consideration that how is the patient going to respond to having quite square teeth. So if you kind of show them and you explain this to them, basically what you can do is they may turn around and go, oh no, I don't want these big square teeth. And if they've got a very high smile line, they go, oh no, I don't want these big square teeth. And then you would tend to go for the gingival mask. So that tends to be less applicable, the BioClear, if you've got multiples and if you've got a very high smile line and you think you're going to make the teeth look very square. So that could be a consideration as well. So hopefully that will clear that up for you a little bit. Okay, we're nearly done, so I'll come back. We've got a couple of minutes left, so certainly if you have any more questions, please email me before the hands-on course. So any questions you have, email me. The closer it gets to the course, and if we have multiple questions of the same, we may hold it for the course. But certainly what I'll do is I'll respond to all of them. But it may be that some of the emails, if they're more practical based, we can do it on the course as well. And certainly when you come in for the course on the first day, just give me a list of any questions you have. And certainly as the course goes on, we will basically answer any of your questions there as well. So don't hesitate just to email me prior to that. So I think we're nearly out of time now, so we're going to wrap it up there. Thanks for all your questions. They've been really, really good questions tonight. Apologies if I haven't answered all of them clearly. If they're product related, bring in the sheet that gives you the product details. And certainly things like the restricted envelope, I can show you the slides for that again on the course, and I've got study models of them, etc., for when we do the hands-on practicals. So enjoy the rest of your evening, everybody, and I'll look forward to seeing you all in just a few weeks now for the hands-on session. Okay then, and good night, everybody.